Oh, hi, I'm Cynthia Santillan. I'm a radiologist at UC San Diego. I've been at UC San Diego since 2005 when I did my body imaging fellowship there, and I've been in practice now for over 20 years as a radiologist. So I'll be talking about that later today.
Okay, we will jump into the presentation, assuming I can figure out how to screen share because I am bad at technology. Da, 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 da. Okay, can everybody see my screen?
Yeah, we can see your screen.
Yeah. Okay, so today I'm going to be presenting about radiology, and I thought at the very beginning I would just have a little interesting story from before. This is a news post that happened about a year ago now, and it was caused by an MRI machine pulling let's call it a foreign body through someone that they weren't supposed to have, and they were misled by the label. And you can read from the headline, and you can look at the picture to the right to see that that was not supposed to be in their abdomen and caused massive damage. And they're also trying to sue the MRI company as well as the manufacturer of the silicone toy that they were using. So a little bit more about me. I'm the medical workshop coordinator. I'm currently interested in emergency medicine. I like radiology and orthopedics as well. I like to play sports, currently play rugby among some others. I like to play some video games, and I like to spend a lot of time with my friends. And I'm always happy to respond to emails if you have any questions about this presentation or anything else. So for the types of imaging that we'll be covering today, we'll go over X-ray, CAT scans, fluoroscopy, ultrasound, nuclear medicine, and MRI, which is my personal favorite and the one I have the most experience with, and also the one which Dr. Santion has the very most experience with. So X-ray. So it's mostly used on the bones, the chest, and looking for foreign bodies. And this is because it shoots X-ray, which type of radiation. It's not a high level of radiation, but it's a type of radiation, and it's on the electromagnetic spectrum. And it goes in and it bounces off these foreign objects in your body or dense objects in your body. So bones are very dense, and other things that are dense are like foreign objects, maybe metal or anything else that shouldn't be in your body that isn't soft like tissue would get picked up by X-ray and it'll show us like a bright spot.
So also know that mammography is also a type of X-ray, just so
Yes.
you guys know.
And I just did realize something. Give me 1 second. There you go. And these get absorbed by the hard tissue, and they become brighter spots. And it's used for the chest because you also have a lot of dense things in your chest, like such as bone. So it's great for observing any possible damage or fractures, breaks, which are the same thing. But anything possible wrong with the chest. It's also great for looking at like the soft tissue, see that there's no scarring because that's denser and will show up a bit brighter. Now for CAT scans, these are used a lot of time for trauma and observing cancer surgery in the brain. And you can imagine it as a X-ray from 360 degrees. It spins around and it images multiple different angles with an X-ray, which allows you to get a more complete picture and render like a three-dimensional image of what you're looking at. And given that it's multiple X-rays at a time, the radiation exposure is higher, but none of the radiation exposure for these imaging is at any level to be concerned about if you're getting a scanning here or there. This is like if we're talking about like workers that are X-raying people constantly, that's why they wear a lead vest or they hide behind a shielding panel to protect them against the radiation because they do it day in and day out. If you're just a patient getting scanned, the radiation exposure is very minimal and doesn't really pose a risk to you. And now for fluoroscopy. It's this is used a lot of times in surgery. It's a continuous X-ray of a plane of the person, and you can see in the little image video to the right is it can help monitor how a person's body works and how the fluid is moving through their body. And it's great for surgery because it allows you to see where you're putting guide wires in and how they're moving, along with how anything that you're doing, blood flow and everything is changing as you operate on a person because you don't want to know. You want to operate on a person and not be able to see these images because you'll be operating a little bit more blind. This gives you real-time updates on what's happening, what and how the body is responding to what you're doing. And now ultrasound is one of the most common types of imaging you'll see, especially in the ER. This is used on a lot in OBGYN because it's great for looking at soft tissues. It sends sound waves or radio waves into your body, which bounce back. It has no radiation exposure, which is perfect for just longevity and safety. And it's used a lot of time in places that in the ER for quick and rapid assessments, along with places that may not have the money to get CAT scans or MRI machines because those are really expensive. And these are relatively cheap in accordance to a lot of things. You could get your own personal ultrasound machine for under $1,000. And the one problem with ultrasound machines is it is very dependent on the user. So if you have someone that's really good at ultrasound imaging, you can gain a lot of information from it. But if you use someone that may be bad at using the technology, then they could miss things, they could give you an improper diagnosis, which could lead to further complications down the medical line. And if you're wondering what this looks like, it's in movies, you would see like normally a pregnant person on a table, and they would have the ultrasound jelly, which they place on the person's stomach, and then they have that probe that they rub along their stomach to get imaging and generate an image of the fetus, which you can see in the bottom right. The jelly is so it forms a better barrier for the waves to travel through because sound waves could get dispersed if it was doesn't have direct contact, but the jelly provides that direct contact between the probe and the belly and the rest of the tissue, which allows that image to be generated more clearly and with less distortion and static in it. And now for nuclear medicine, this one has the theoretically highest exposure of radiation, but that's because of what you can do after it. It's not the imaging itself. So this is a lot of time is used for oncology in specific, along with neuro and looking at specific tissues, but it's used a lot in oncology for radiation oncology. And now how this works is it sends photons which are then received, which then hit the cells and which are then received by the scanner and allows you to see them.
So hold on, Jaden. So the patient gets infused with some sort of a radiopharmaceutical, so something that's going to emit radiation. So the radiation is coming from the patient, from those areas that have activity for whatever reason, that have been tagged to go to those areas for whatever reason. And then those photons are then received by the equipment. So we actually don't, we're not, this machine, for example, is not actually sending radiation into the patient. It's actually receiving the radiation the patient is emitting for nuclear medicine.
Yes, then after receiving these images, you can then use targeted isotopes that can go into the body and attach to where these radiation and these tracers are. It can help it target and destroy the cancers in a very specific way and specifically latch onto these areas that you're trying to target. So it can be a more direct way in order to eliminate cancer and not cause as much collateral damage to the rest of the body with lots of drugs like different types of radiation therapy that are go outside and are still very targeted, but cause more damage to surrounding tissues, which could cause problems later on. And now my personal favorite, which is MRI imaging. So this is used in a lot of imaging. One major con about MRI imaging, which isn't listed here, is there's sometimes a very long wait for these because it is used so much and it helps uh, doctors find so much information about a patient that there needs to be a lot of MRIs given to patients, and there's only so many MRI machines. These machines are very expensive. These machines are always running and can sometimes be dangerous, which is why there's very strict protocols regarding them. And the very gist of how an MRI machine works is it is a giant magnet that spins around polarizing cells, unpolarizing them, which allows you to see how many protons are in the cell, how many neutrons are in the cell, and that helps determine what type of tissue it is, and that helps generate an image. And then a computer runs a formula and generates this image back onto what you then see in the image. I know that was a bit confusing, maybe. Now, since this is a giant magnet and it is never turned off, or almost never turned off unless it's something really bad goes on or it's being decommissioned, you can have no metal or in the patient or around the patient or in the room at any time. Like in movies, whenever you see someone like take off their metal stuff in the MRI room, that would never happen. You take it off beforehand because the machine doesn't get turned on. It's always on, the magnet's always running, and any metal would get sucked into the machine or cause damage to the people or the machine. So, in out of high school, I did research at UCSD, and I was first a volunteer, and I was later hired as a research assistant for a short period of time. I was in charge of doing research concerning cervical imaging and repeatability for a new type of imaging, a newer type of imaging called RSI, which is a type of imaging that uses an MRI and looks at how water moves through the body and using MRI to categorize that. So you could figure out what type of tissue is there given how much water is moving. Like very free floating tissue, like such as fat that has a lot of water and can move readily available, would have different movement of water in it compared to like a tumor, which is very dense and the water is hard for it to move across different places. So the different types of tissue would give you different types of images, giving you brighter and darker spots. So if you look at the picture on the left, you can see like the bladder at C2, which is like a much brighter spot at the top. And then you have like the ovary on the right, which is also a little different. And that's why it's very bright on the bottom images. The top images did not have a lot of restrictions, so there was not really much generated there. But, and then what I did besides looking at the images, I was mainly in charge of doing the stats for the paper and abstract that was then made after. So on the right was like a different types of things that we had to do, which was we made a bland Altman plot for our stats, which is commonly used for radiology, especially for repeatability testing. So for research, what I specifically did was I reviewed MRIs and conducted data analysis. I drew circles on, let's see, the bladder at the top of this and also on the cervix and the outer cervix to then isolate those values, which allowed me to generate data that I then analyzed in order to figure out if what we were doing was a repeatable process. Basically, if what we're doing could be incorporated into the standard imaging practice. Because if it's not repeatable, if you don't get dependable results from what you're doing, then there's no point in using it because that means it's not an accurate method of analyzing data. But if what we set out to prove was that it was repeatable and that we could use this as a standard of imaging, so we could image people faster and hopefully be able to diagnose and help them get further treatment if they needed to later. What out of what I was doing, what I got was I presented at a conference. I wrote an abstract, and I am currently writing a paper finishing the research that I started at UCSD. And the whole goal of this research, besides proving that this was a repeatable method, was so people in post-operation, so after people got treatment for possible like cervix cancer or other types of cancer in their body, we could hopefully image them faster than current imaging methods because current imaging methods before this make people wait multiple weeks to months. And our goal with this is with this method, we could start scanning people and start assessing how they're behaving post-op in as little as 2 weeks, which can allow people to alter their treatment if it's not working, or can allow people to get or give people peace of mind knowing that their treatment is working sooner than having them to wait a much longer time before they get this confirmation that something is actually happening. And out of my research, what I gained was I worked in a lab for a lot of time, which allowed me to gain many soft skills and hard skills that I learned from this. I gained publications, which I could put on my resume in the future. And while I did eventually move from being a volunteer to becoming employed, I did gain some money, which is always a plus because money is always good. It's nice. I made friends during while I was doing our work, and I got to meet so many other people while researching because you have your group that you research with, but everybody collaborates and it's a very friendly atmosphere for the most part. So you gain what you put into it. And if you decide to talk to a bunch of other people, you decide to learn as much about all the other fields that are around you, you can gain many different, I don't want to say connections, but you can gain much more knowledge than what you had previously. Like there's also right next to our lab was the prostate image is they're always help much more enjoyable for you to do. So in terms of radiology and for like positions, if you're interested in this field and you want to get into it and want to start doing internships or get it just like get familiar with the field, a lot of the times, I'll say this up front, you're not going to be able to do much of the actual imaging with a patient. And this is because most of the actual image requires certifications that happen post-grad a lot of the time. So like X-ray, I mean, not necessarily post-grad, but like they require schooling for that, like X-ray techs and other stuff like that. They require multiple different certifications for them to do their jobs. So you likely won't be able to do the actual imaging, but you can do many other things to be around the field. So if you work at the hospital and you do shadowing, for instance, if you shadow a radiologist, they can help show you how to read images. They can show you what a daily life of a radiologist is like. And if you want to get these hospital or shadowing positions, I know that there are multiple forms to fill out at Kaiser that let you apply, like Kaiser near here, that let you apply for shadowing along with Sutter. You can also cold email doctors that you find, like by looking them up or looking at their page, and by cold emailing them, you can gain some information and maybe they can point you towards resources that you maybe didn't know about. Along with the just cold emailing doctors, there's also just volunteer programs for radiology, though a lot of the times that they'll put you more in a receptionary type role and not as much as a working with patients. So if that's what you wanted, I would ask more questions to the volunteer program to see what they can do for you. But a lot of hospitals do have opportunities for you to volunteer. And lastly, if you want to get into research about radiology, there's always radiologists conducting a lot of research, especially here in Davis. Since Davis does have a hospital and they have a very active research group and lots of professors, there's a lot of research going on. And just by cold emailing or looking at their page and reading some of the research and finding what they find interesting, what you could really connect with, you can get into imaging that way. Um, like some of the previous presentations said about cold emailing, reading their research, and actually like learning what you want to talk to them and what you want to get out of it, and will make you a much better candidate than if you just see a doctor and decide to email them. Make sure that you actually your goals align with what the doctor's goals are because it makes you much more genuine and gives you a much better chance of getting into there than just emailing a bunch of random radiologists hoping you get in. And then without further ado, we will have our doctor present to us. And if you ever want to annoy her, there's no difference between a fractured bone and a broken bone. But if you tell her that there's a difference between a fractured bone and a broken bone, it will drive her insane. Thank you for listening to my presentation.
Excellent. Thanks, Jaden, for all that information. Let me see if I can share my screen here. Share. All right, can you guys see that?
Yeah.
Yes, we can.
Okay, perfect. All right, so again, I'm Cynthia Santillan. I'm a radiologist at UC San Diego. I am do work clinically, which means I read studies most of my time when I'm working. But I also have some administrative responsibilities. I'm the vice chair of clinical operations for the department, which means I do a lot of stuff that doesn't involve reading images, but involves trying to make sure that we are getting imaging as quickly and as reliably in our patients that come to UCSD. I won't be talking about that piece, but I'm always happy to talk about kind of administrative, sort of managerial aspects of healthcare. But today I'll be talking more about those stuff when I'm reading studies. So. Let's see. So I just want to tell you a little bit of how I got to where I am now. Went to high school in the 90s in Amarillo, Texas, which is a very small town, much relatively small town in Texas. For those of you that are familiar with how Texas is, that little square bit on the top, that's the Panhandle, and Amarillo is right in the middle of that. Graduated in 1992 from high school, and then I went to MIT for college, and I got degrees in biology and chemical engineering there. And then I went to med school at Washington University, which is in St. Louis, Missouri, and I got my MD in the year 2000. After that, so while in med school, I had a couple of choice things that I was thinking about doing for my career after med school. Um, for me, I had narrowed my choices down to surgery, pathology, or radiology. And so in my last year, third year of medical school, which you have to apply for your residencies at the beginning of your fourth year. So during the third year of med school, at the very beginning of my fourth year of med school, I went and I did specific rotations in those three areas to help me decide what I was going to apply into. And I fell in love with radiology when I was doing my rotation in radiology, so I ended up applying in radiology. In retrospect, I really liked surgery, I really liked pathology and radiology. And the thing that all those things have in common is a huge reliance on anatomy. And so I really like anatomy. I like how the body works. I like how it's put together. I like how all those things work together to kind of keep us going on a day-to-day basis. I found that very fascinating. So anyway, so currently radiology residency training consists of 1 year of a preliminary year. And so you do 1 year in something general, either internal medicine or surgery. It's called a prelim year. And then you do 4 years of training in radiology specifically. So it's a total of 5 years of post-MD training to become a radiologist. So I did my first year at Forest Park Hospital, which is a small kind of community hospital in St. Louis, as an internal medicine intern. And then I did my 4 years of radiology specific training at the Mallinckrodt Institute of Radiology, which is affiliated with Washington University in St. Louis. When I finished my training in radiology, then I wanted to do a fellowship. Many people do a fellowship after they finish radiology training, but not everybody does. It kind of depends on what you're thinking about doing in the future. I wanted to do body imaging, and I was thinking that I would probably, I was trying to think of maybe I might end up in academics or a university practice, in which case it's kind of important for you to do some sort of specialty training. So I did what's called a body imaging fellowship at UC San Diego. I finished that in 2006, and then right when I was done with training, I stayed on as faculty, and I've been at UCSD ever since. Um, and I think that I just want to be really clear here. I love my job. Like I love what I do every day. And I think I feel truly lucky that I get to make a career, make a living, doing something that I really enjoy doing every day. It's a great field. I think that you can really customize your practice and your field, in ways that, may not have the flexibility to do so in other specialties in medicine. So I feel like it's been the perfect fit for me. I do research predominantly in liver imaging and bowel imaging. And as part of that, I get to speak at societies, I get to be part of different societies. I speak around the world. I'm going to Argentina next week to speak in Cordoba. I've been to Brazil, I've been to Japan, I've been to Mexico, and it's been a really fulfilling career so far. So I've been really like to do what I'm doing. But I want to tell you a little bit about what the different specialties are in radiology, because I think this is something that's, um, there's a couple other fields in medicine where after you've kind of done your residency, then you do something that could be very different from the other person who did the exact same residency and end up practicing in very different ways. And radiology is similar with that respect, that you can practice in any one of these different areas and do specialty training in most of them. And you'd have kind of very different careers and very different uh, areas of expertise. So I'm a body imager, which basically means that I specialize in evaluation of structures below your lungs and above the groin, so above your legs. So that whole area of the what we call the abdomen pelvis is my area of expertise, and I image it in all the different modalities that Jaden talked about. So on a given day, I could be reading ultrasound, I could be doing fluoroscopy, MRI, CAT scans, and X-rays of, just those body parts. So, for example, this is an ultrasound of a uterus. As Jaden mentioned, we do a lot of ultrasound imaging for the female pelvis. It's kind of a bread and butter sort of go-to, particularly since it doesn't have any radiation. This is an ultrasound of the testicles, also another area that's very well evaluated with ultrasound because it's kind of close to the skin surface and we can see those structures really well. This is an X-ray of the abdomen. Do those still on a regular basis. We also do a lot of some of the vascular imaging on ultrasound. So this is an example of we're looking at this person's leg veins to make sure there's not a clot in their leg veins because people who often are in the hospital are sick, they're not moving around a lot, and they have a tendency to develop like clots in their legs. So I read the ultrasounds for those things. Now, you might be looking at all these images and say, oh my gosh, she's so busy getting all these images. I'm not getting these images. For example, for ultrasound, a sonographer is actually the person who's scanning the patient. I rely on the sonographer to be good at what they do because, as Jaden said, sonography is very operator dependent. We liken sonography as if you're in a dark room and you turn on a flashlight. You can see that area that the flashlight is shining on really, really well, but you have no idea what's going on around you. And only if the person shines the flashlight in the right places will you be able to find the things that you need to see and then you need to look at. So the person who's operating that flashlight, the sonographer, needs to know what structures to look for and make sure they're giving the radiologist, me, the appropriate information because I'm just going to be looking at the images later. But anyway, so I do ultrasound, I do radiography, I do CT scanning, CAT scanning, abdomen, pelvis, kind of our bread and butter, sort of the person who walks in with abdominal pain to the ER, they're often going to get CAT scan. And then we do a lot of MRI. The liver is an organ that we particularly do a lot of imaging in MRI and body imaging. This is an example of an MR elastography. So we can use an MR with a specific paddle that's put on top of the patient to kind of vibrates and sends sound waves into the motion waves into the patient. And then we use the MRI to kind of follow those motion waves and we can tell someone how stiff their liver is. And so liver stiffness is often kind of a measure of, how healthy the patient's liver is. Patients who have very, very stiff livers can sometimes means that their liver is scarred in or has cirrhosis. And that mean different things about their patients, different ways that patient might need to be treated in the future. So that's sort of body imaging. Cardiothoracic imaging is everything kind of from the diaphragm up to kind of your shoulders. Okay. So lungs, all the large vessels that are attached to the heart and the heart itself. And so they also will do a lot of CAT scanning, a lot of chest radiographs, many, many chest x-rays that they're looking. Every patient in the hospital gets a chest x-ray at some point during their stay. But they look for lung cancers. They're also looking at, cardiac abnormalities as well, or areas of injury to the aorta, the vessel that's coming out of your heart, which can sometimes be injured in kind of motor vehicle accidents and things like that. Neuroradiology has everything to do with the nervous system, right? So anything, the head and the spine and the neck is usually the field of expertise for neuroradiology. And so body imaging, has a 1-year fellowship of specialization. Cardiothoracic imaging has about a 1-year fellowship of specialization. Neuroradiology can be 1 or 2 years, depending on where you're doing your fellowship. And they do a lot of predominantly MRI and CAT scanning. So this is an MRI of the brain that you can see here. Here's a CAT scan of someone's neck. You can see that the jaw is kind of included here. So we can see this person's teeth and any cavities that they may have. Here's a side view here of the brain on a CAT scan. And this is an MRI here of the spine. So the lumbar spine here, this lower spine here where you can see the bright stuff here is the fluid around the spinal cord, which is this kind of thing that's dangling in the middle down here. Really important, as you can imagine, as part of the team that's taking care of patients who have strokes, patients who may have some sort of brain tumors, or other neurologic issues. Musculoskeletal radiology, they rely a lot on plain films. So this is kind of an X-ray of the hip, an X-ray of the ankle, but they do a lot of CAT scanning as well as MRI. So this is an MRI of the knee. So if you are, and one of the things that's interesting about radiology is, depending on what fields of expertise you choose to go into, it really dictates the people that you are going to be working with most closely, right? So the musculoskeletal radiologists, they know all the orthopedic surgeons in UCSD, right? Because they're constantly talking back and forth with them. They're the ones who do the imaging at UCSD. We do the imaging for our Padres, our local sports teams. They come in and get their imaging by the experts at UCSD. Um, MSK radiologists will also sometimes do joint injections. So sometimes they'll be taking a needle using fluoroscopy and injecting something, for example, in the hip joint. They'll inject dye in there and then later look and see where that dye goes on an MRI. So they'll be doing kind of a combo two-in-one sort of examination where they're going to the patient, they're putting a needle in a specific space, injecting dye, and then that patient goes to the MRI scanner right afterwards, and then we look and see where that dye went and helps outline structures. So that's something that's often done in the hips and shoulders. Some MSK radiologists will actually do therapeutic injections of joints as well. So someone who may be having a lot of pain in a certain joint, they'll do an injection. They'll be using the X-ray, the fluoroscopy to guide the needle. They'll get it, make sure the needle's in the right space, and then they can administer something to help with someone's pain or symptoms and make them feel better for a period of time. Nuclear medicine, as Jaden mentioned, is one where we actually are it's sort of the opposite, right? So a lot of these things I've been talking about, CAT scans, MRI, fluoroscopy, there's a machine that's sending something into the patient. Nuclear medicine, we are giving the patient some sort of radioisotope, something that kind of emits radioactivity. It's being injected into them. And then we have a machine on the outside that measures where that radiation is coming from and how intense it is in different places. And we can use this for both diagnostic as well as therapeutic things. So for example, here we can see this is what's called a bone scan. And so we gave them something that tends to localize to areas where there's a lot of bone turnover. So that can tell us there's something either wrong with that bone, it's fractured, but often it's being used because that patient might have a cancer that we're worried has gone to their bones. And so those areas where the cancer's gone to the bones, those bones are trying to rapidly try to heal themselves, trying to fight back and whatnot. And so there's a lot of activity in those areas, and that's where that radiation will localize to, and then we can see that. So for example, this person has a lot of radiation, has a lot of activity happening here in their right pelvis. So it tells us there's probably involvement there from whatever tumor they may have. And every one of these little tiny little areas you can see here in the spine is probably an area of disease as well. They have an area there and then a bunch of things in the spine. This is a PET scan. So a lot of PET scans, they use FDG. So it's a type of radioisotope that's usually attached to a form of sugar, like a glucose molecule. And so glucose is used by many of our metabolically active parts of the body. A lot is used by your brain. So your brain relies a lot on glucose. And you can see that in the PET scan, the brain lights up, is really bright on our PET scans, but that's normal because the brain normally uses glucose. But the rest of the body doesn't use glucose quite as intensely as others. And so then we look to see if there's tumor cells that are using up a lot of glucose. But what's interesting in the theranostics avenue is that there's a lot of research of attaching kind of this radioactivity at higher doses than what we use for just taking pictures, where we can actually attach it to something that we know will localize to a specific tumor. So one of the hottest applications for this is in prostate cancer now. So there's something called a PSMA, which is something that's we use to that tends to be present on the outside of prostate cancer cells. And so they've developed a molecule that will attach to that thing that's on the outside of prostate cancer cells, and then they've attached something that's radioactive to that thing. And so now you infuse it into the patient, it localizes to where the tumor is. It does basically radiation oncology. It treats that area of tumor by radiating it without causing as much collateral damage as other forms of chemotherapy may cause. And as you can imagine, the possibilities are endless, right? And so nuclear medicine, I think, is a really exciting field right now. It's what they call theranostics, where we're getting kind of finding out where the tumor is, staging the tumor, but can also treat it at the same time. So that's really exciting. Interventional radiology. Now, more recently, there's actually a separate residency training pathway that you can use for interventional radiology. So I did what's called diagnostic radiology, but nowadays you can actually apply directly into interventional radiology, where you get so instead of a total of 4 years of dedicated to radiology, diagnostic radiology, you do like 2.5 years of diagnostic radiology and 1.5 years specific to interventional radiology. So interventional radiology is sort of kind of self-describing, right? It's using radiology to guide you to do things to that patient, right? So these are people that are doing things to patients that are dependent upon imaging guidance to get to be successful at that. So for example, this is a needle that's going in, they're doing a CAT scan, they're using that CAT scan to guide that needle into a tumor in a bone so they can biopsy that bone. This is really cool. So this is an image, for example, of someone who is in the midst of what we call an embolization of a liver tumor. So you can see this little squiggly line here. That's a catheter that is at the patient's groin. So they made a tiny little cut, put a catheter into a vessel at that patient's groin, used fluoroscopy to guide that. So they're watching the catheter, they're taking x-rays, they're using fluoroscopy to guide where they're going to put that catheter, injecting dye as they go to kind of track the vessels. And they can guide this catheter up from your groin vessels, up into your larger vessels in the middle of your abdomen, go into one of those branch vessels that we know is feeding the liver, go into the liver, and then even go further into the liver, specifically to the tiny branch that's feeding the tumor that we want to treat. And then they'll treat it. They'll put in chemotherapy, or they can even put in radiation loaded little glass beads that will go into the area where the tumor is. So you can imagine someone who has a liver tumor, they can be treated by a tiny little incision in their groin and have that tumor kind of killed from the inside, either by cutting off its gut blood supply, giving it some chemotherapy, or even radiating it from the inside. And so that's, really exciting kind of next level stuff. And they can do this anywhere in the body. So they do a lot of stuff that's percutaneous, meaning they're coming in from the skin and kind of using imaging guidance from there. Or they can do it via endovascular, which means they're going into the nearest easily accessible blood vessel and then guiding a catheter to provide treatment in that way. So, and they can also do a lot of biopsies in that way as well. So, breast imaging. So there's a whole field. You do 1 year fellowship of just looking at breast imaging, and then you can do that for the rest of your life, just imaging breasts, because as you can imagine, lots of people get mammograms, right? It's a recommended surveillance for like every woman once they get to a certain age, as well as even earlier if they have specific risk factors. And so you've got all these women who are getting mammographies every year from age X until they stop getting their screening. So there's many, many women who need this. And then when they find an abnormality, it needs to be worked up. So breast imaging, like interventional radiology, and like how I described MSK radiology, they are also another type of radiologists that are actually going to be doing things to the patient. So the breast imagers will read the mammograms. If something is wrong in your mammogram, they may get called back for something called a diagnostic mammogram, where they do a couple of images and the radiologist is looking at it as the images come across. And if they see something, they can then do an ultrasound guided biopsy, see if they can see an ultrasound and stick a needle in it and get a biopsy to find out what tissue's there. They can do a biopsy via mammogram, the stereotactic guided biopsy. And so the breast imagers are also often doing biopsies of whatever they see in the breasts. And this is a breast MRI. So you can see here, there's a bunch of little bright spots here in this patient's breast right there. You can see these dark areas. This person has actually had implants in the past, and we're evaluating the breast tissue that's kind of on top of the implants here. And so you can use the MRI. We give them dye with the MRI. And then you can see the areas that are kind of bright. That means that they're enhancing. That means that we're a little bit worried there might be a tumor there. And they can even do biopsies, MR-guided biopsies as well in breast imaging. So a lot of work to be done there. It's a kind of exciting field as well. And pediatric radiology. Now, these guys are superstars, right? Because pediatric radiologists do all of these things, but in kids. And it's a very different field because you'll hear people say that kids are not little adults. Kids have completely different types of diseases that they can suffer from or are at risk for. And so ideally, you'd want to have an expert who knows specifically what things can go wrong in kids, evaluating kids' imaging. They do a lot of radiographs. This is also kind of some bowel imaging where they're swallowing, they had a tube down in the baby's, it's down into their stomach, and they gave some dye that way, and they were kind of tracking it going through their bowel to make sure it's normal. Babies, when they're first born, they will sometimes get a head ultrasound if we think that they're at risk for having had bleeding in their head, which can be associated with prematurity, or if they had a traumatic birth. And so since the babies often have what we call kind of those soft spots, those areas where the bones haven't quite stitched themselves together, we can actually use ultrasound to actually look at the inside of a baby's brain. And so this is kind of an image here from the midline of the baby brain. And then trauma emergency imaging, this is kind of a newer field. These are people that specialize in things that can coming in through the ER. So they're not doing a lot of cancer heavy sort of stuff, right? They're not sitting there kind of counting how many lesions might be in someone's body, but they're looking kind of for more acute, immediate problems. And they're often people that work kind of varied shifts. So much like you can think of the shift life of an emergency room doc who like comes in for like 8, 10 hour, 12 hours, and then kind of clocks off at the end. That's sort of what trauma emergency imaging is like. You're going to be dealing with, things that are, acute, traumatic, and then you kind of clock off at the end of your day. And so they may work, for example, from 7 to 5, 7 a.m. to 5 p.m., or 5 p.m. to 11 p.m., or 11 p.m. to 7 a.m. To help provide coverage, particularly sometimes for some of the more specialty people that are working during the day, but they need to be able to work the next day. And so then we have emergency people that are kind of covering it at night, et cetera. So and then general radiologists, a lot of our private, some people who go into more smaller practices, like I'm in a practice where we have like 70 radiologists. 11 or 12 of those are body imagers like myself. And so then every specialty has a fair number of places, but you could be in a small community area or working at a hospital that maybe doesn't have a big group to support it, or maybe in a more remote location, in which case you'll need to be reading a little bit of everything. And that's totally fine. And that's totally a valid way to practice as well. Um, and though you can imagine those folks need to have expertise kind of broadly in everything. And they're also doing some of the interventional stuff too. They'll be putting needles and drains into an abscess, like a pocket of pus that might have formed somewhere, or putting in a catheter into someone's neck so they can get reliable medication or a port or something else for future access. So those are the kind of the jack of all trades in radiology. And there's a lot of them out there right now still. So but many, even people who practice general radiologists, some of them have done some sort of specialty training ahead of time, and just so they kind of feel a little bit more buffed up in one area or the other. Okay. All right. And I did want to talk a little bit about kind of what the radiology team is. So a lot of times when people who don't know a lot about medical fields, they find out someone is a radiologist, they assume that that's the person who is actually taking the pictures. Sometimes it is. In some places, someone will go in and do the ultrasound themselves and be the radiologist themselves. But in a busy practice or in a large hospital, the radiologist is the physician. They're a doctor. They're an MD or DO, and they're the ones who are kind of looking at the images at the end. But it takes a lot to get those images. So, for example, say someone orders a study on a patient. And that patient needs to be calls in or uses an app like a MyChart app or something else like that to schedule that patient, to schedule it. So there's got to be a scheduler involved to make sure that that patient is getting put into the right slot for the right imaging test that's been requested and has been ordered. They're screening them to make sure it's safe. Like, for example, they don't have metal in them that means that they couldn't get an MRI. So they're screening the patient to make sure it's safe for them to get the imaging study, making sure that patient can get to that equipment safely. So, for example, there may be areas where some of the equipment can tolerate a larger patient as opposed to a smaller patient. So we want to make sure we're getting the patients to the right equipment, and then make sure that they're getting the study at a time when it's appropriate for them. So at UCSD, we have MRIs being done at 24/7. So all night long, our machines are running. And imaging patients, but some people need to have the images checked by a radiologist while they're still there, or something special needs to be done, in which case then those patients need to be scheduled during the day. So there's a lot of work to making sure that we're scanning the right patient at the right place at the right time. Now, when the patient comes to their appointment, they're going to be checked in on the front desk. The front desk person is going to then, put an armband on to make sure that they have the right patient identification, making sure they're there for the right study. Again, checking to make sure there's nothing that's going to keep that patient from safely having that imaging study today. The front desk will then often have the tech assistant will be the person often who will then get the patient from the waiting room, and help them if they need to get changed into a gown or remove something. As you can imagine, if they have like a lot of metal on them or something else like that, it might need to be moved, whether they're getting an MRI, if they're getting a CAT scan, the metal can also get in the way. So making sure they're dressed appropriately, making sure they're comfortable enough for their study. And then sometimes a nurse or a nurse will need to be able to help start an IV if they're going to need to get dye as part of their study. So sometimes there's going to be a nurse here helping as well. And then the images are going to get obtained from the technologist who's operating the machine, their sonographer who's acquiring the images. And that's when the imaging actually happens. Now, that imaging equipment The technologists and sonographers are making sure the imaging equipment is in good state, but there's also a lot of other people to make sure that the imaging equipment is safe. There's a medical physicist who is involved from every step of that imaging equipment ever existing in that space, and the radiation safety officer. So, for example, those two people are going to be working together. The building that you're going to get your studies in was designed with input from these people to make sure that that equipment was safe to be in that location. So they make sure the shielding is appropriately in the room for either radiation, making sure that there's nothing coming into the room that might interfere or cause artifacts with the scan, for example, for an MRI. And then they're doing constant updates, supervision of the equipment, checking on the equipment to make sure it's operating safely. It's not going to cause any patient harm, and it's going to give us appropriate imaging. So once we actually get the images, then and only then does the images come to me as a radiologist in order to look at them. And as you can imagine, IT, information technology, is involved in every single step here. So we have our own sort of set of IT people that work specifically in radiology to help make sure things are running smoothly. So once the images are sent to me, that's still not done, right? There's still things that have to happen. So I, as a radiologist, I'm standing in front of a computer screen, and I've got a list of studies that I need to look at, a list of patients that have had studies done. So I'm going to pick one and I'm going to look at that one. So I have a work list. So sometimes there's a communal work list. We're all working off of the same list of patients. Sometimes there's specific patients that get sent or specific types of studies that get sent to one work list or another. Depends on how things are set up in your place. And so then I pick a study and I'm going to open it up. I'm going to look at the images. Now, if I see if it's just kind of a run-of-the-mill sort of thing, nothing unexpected, or at least nothing too unexpected, I'm going to type a report or I might dictate a report. And then that report will then go into the chart, gets sent to the person who ordered it. If there's something that's an emergency, something unexpected or something needs to be acted on very quickly, then I'm going to, pick up the phone and see if I can call the ordering physician, or else I'll call the reading room assistant. So this is another person who's kind of helping in the radiology space. This person is kind of fielding phone calls, all the phone calls that are coming into the rooms that we're working at. Or I'll say, hey, I've got something emergent in this patient. I need to get a hold of the doctor. And I said, can you please get a hold of this doctor for me? So then they'll work on trying to get a hold of that doctor. They'll then come back to me and then I can convey the report because I have to document that I talked to someone if it's something that's really important or has to be acted on very urgently. So I just want to make sure that I just want to convey to you that this is like a whole team effort. And every person in this team, every part of this team is important to make sure that all of this runs smoothly, that patients get the appropriate imaging, and the results get to where they need to go. So any questions about that? I know I just want to make sure that I'm kind of going at the right pace or giving you the sort of information that you want to have, or if there's any other information you guys want to have before I go on to the next little bit here. Okay, if you're shy, you're welcome to put something in the chat while I kind of go over to the next bit here as well. So I gave Jaden a couple of options about the things that we could talk about relative to radiology, and he thought that maybe talking a little bit about AI might be interesting. So just a couple minutes to talk about a little bit how I see my take on how AI is going to be working in the future for radiology. This is an article that just came out in February on the CNN web site, and it says radiology has become a case study for why AI won't replace human workers. And obviously, I'm a bit biased, but I think it's going to be a long time we see radiologists kind of disappear because of AI. The predictions of AI killing the field of radiology have been made ever since AI started, and it has not looked like it's come to that point. I'm not saying that I'm not using AI. I'm not saying that AI isn't going to change how I practice, but I doubt it's going to be replacing radiologists entirely anytime soon. And part of this is manifested by the fact that radiologists, if anything, we are kind of leading the field in AI development because we recognize how important it is and how it can really change how we practice and make our lives a lot easier. This is the American College of Radiology website discussing AI. They actually offer AI certifications so that you can go in and do some sort of modules and training and say that you kind of learned the basics of how AI are. And this is actually important. For example, if you're kind of like the AI person in your group or in your setting, you're going to be the one that someone's going to say, hey, these people just reached out to us. They have this cool new tool. Should we buy it? And so then you need to decide, okay, What is it that they're doing? Is it actually an improvement upon what we're doing now? Is it worth the money? How secure is there patient data that's going to be leaving our system? And if so, is it done in a way that it's secure, that we know it's not going to be hacked or misused in some way? And are my radiologists or the people who are looking at the reports going to be happy, are going to see this as an improvement, and is this something they want? So you might be the person who needs to evaluate these sorts of new tools. And that's not just for radiology, that's for kind of everything. So I think that having some degree of knowledge about what AI is great, but you can also become kind of the expert of AI in whatever field you end up going into, because it's a very valuable skill. And see, these are some of the tools that you might be asked to evaluate. So AI Doc is a company that actually we use at UCSD. I'll tell you a little bit about how we used AI Doc. And then RAD-AI, we're actually in the process of evaluating for possibly using them at UCSD. And I'll tell you a little bit about kind of the products that they're offering. But you just type AI radiology, and you'll come up with like all of these different places that are telling you, trying to teach you about AI, but also trying to sell you something. Lots of people trying to sell you something. I am on the board of the Radiological Society of North America, which is the largest professional radiology society in the world. And speaking from my own kind of perspective, we do a lot to talk about talking about AI and educating radiologists about AI. There's actually a journal. We have a separate journal called Radiology Artificial Intelligence, just to handle and to vet articles of research, review articles, etc., specific to the field of artificial intelligence applications in radiology. And this is just a picture of the landing page for that journal there. Every year, RSNA hosts an AI challenge. So you can see here we've been having AI challenges since prior to 2019, where we say, hey, we want to see everyone to compete to see how well they can develop a tool that is going to address this specific problem. So as you can imagine, we're trying to make it timely as we go. So in 2021, for example, it was the COVID-19 AI detection challenge. So people were encouraged to develop tools that would look at chest radiographs and be able to predict whether that patient had COVID-19 or not. And this year is knee MRI to evaluate knee injuries on MRI, or at least stratify them or categorize them in some way. So I showed you that image earlier, kind of the pathway, the flow chart of the patient kind of going through the radiology ecosystem. But AI can help in multiple different ways, and it doesn't have to be one and done interpreting the images. That's not kind of where I see AI really helping my job right now. There's just so many other things that it can help. So for example, I talked about the importance of making sure that the right patient is getting on the right piece of equipment at the right time for the right examination. Artificial intelligence can help with that. It can also help with doing what we call protocoling a study. So if I go in to get a CAT scan of my liver because I'm worried that I might have a liver tumor, that's a very, very different type of CAT scan than the CAT scan that may be done for someone if they have an aneurysm or their aorta, or they're worried that they have a tumor in their pancreas. Those are different ways that we do the studies differently. And so then making sure that the study is done not just on the right machine, at the right location, at the right time, but also the right type of studies being done at that time. That's another tool that we can have AI help us with. Um, Giving that sonographer or the technologist live feedback while they're getting the images, that the image quality is appropriate, that they're imaging the right, that they're not only just doing the right type of study, but they're also making sure that they're getting images that that are appropriate for the indication for the thing that the doctor wants to be looking at. And so I just want to make sure I want to make sure I get to questions as we go. So I just saw someone put in something in the chat. This is, who decides whether scan should be done with or without radiation? So the with or without radiation is a decision that's made when we decide what type of imaging modality should be done. So a CAT scan will always be done with radiation. An MRI will always be done without radiation. Ultrasound also is without radiation. And the type of study that's done is very specific to often the organ that's being evaluated and the type of problem that we're looking to evaluate. So, for example, if I need to look at, say a woman comes in who is having abnormal bleeding, abnormal vaginal bleeding, and they're like 25 years old, it's perfectly reasonable to start with an ultrasound. And so if someone says, I want to do a CAT scan for that, as a radiologist, I'm going to say, I'm going to reach out to the doctor and say, hey, you know what? This might not be the right scan to do for this indication. Why don't we start with an ultrasound, which will give us an answer relatively quickly and reliably. And then if we see something that might need something else to be done, then we can do another test. So it's a little bit of a back and forth in education. It's on me sometimes to educate the person who's ordering the study to make sure that they're ordering the correct study for what they say they're looking for. But also, as the person who is ordering the studies, as you go through your training, as you learn your education, you'll also learn also kind of what the right studies are being done. So for example, if I'm looking to do, there's a specific type of tumors that might be in the liver. And I know that I can tell the difference between tumor A and tumor B if I see it on an MRI, but I won't be able to make that difference on the CAT scan. And so once I know that patient is coming in to evaluate the difference between those two tumors, if someone orders a CAT scan, I can say, well, you should probably get an MRI instead. Now, what happens when I tell them they need get a different study, that's always sometimes a little bit painful because then that person might have had insurance approve the original study that was ordered. So now they have to go back to their insurance agents and get all those sort of things. And, unfortunately, some of this can be patient driven, and often patients don't totally understand why one type of study is better than the other. They just hear, oh, I'm going to get dye for this, that's bad, or oh, I'm going to get radiation for this, and that's bad. And unfortunately, you have to take the bigger picture approach to these sorts of things. So, as Jaden said, if you're going to be getting a CAT scan to follow a tumor that might kill you if we don't catch it early, then it's probably worth the radiation of doing that CAT scan in order to do that, for example. Okay. Now, so I was talking a little bit about how AI kind of intervenes in these sorts of steps in the process, but it also intervenes. It also can help in the part where it gets to me, right? So one of the ways that we use an artificial intelligence agent at UCSD is for work list stratification. So I I can sometimes have a work list that's got 300 studies on it. I could have a work list that's got 30 studies on it. Regardless, there's always going to be one study that's going to be read first, and there's going to be another study that's going to be read last. So we have a tool that kind of looks at the studies that are rating on the list and is actually looking at the images and it flags them and says, hey, this one might have something bad on it. Why don't you read this one sooner? And it'll bump it up to the top of the list. Now, the AI tool that we use for this is only looking for very specific diagnoses, right? It's looking for 5 or 6 different things that would be what it calls kind of emergent sort of things, and that it can reliably, or at least it's been tested and trained well enough to detect. Like, for example, it looks for blood in the brain. So this one is always running in the background on the list of studies that has CAT scans of the head. And the studies that it says, hey, I think there might be blood on this one, it'll flag it. And so then it can get moved up to the top of the list, and the radiologist can look at it sooner rather than later, right? So if there is something bad, that they can act on it sooner, they can tell the ordering physician something about it sooner. So it's not looking at the whole head. It's not generating a report for the whole head. It's not looking at everything else. It's not looking for tumors. It's not looking for all the other things that I've been trained to look for. But it has specifically been trained to say, hey, there might be blood here. Maybe you should look at this one first. So that's a tool that I think is in no way a threat to my career, but it benefits patients and it benefits me because I can see, hopefully I can catch those things that might be better off not waiting too long to get read. We have things like computer-aided detection, which has been around a long time. It's not really AI, but it's often used, for example, in mammography, where the computer will sit there and say, hey, there's a couple of little areas here that look a little bit different or a little bit abnormal. Why don't you take a look at those? And then the radiologist will sit there and kind of check them and to double check those areas and make sure that they're okay or not okay. There are tools that will help generating the report in that, for example, I can start dictating what I think about I'm seeing on the study. And I could do it like as if I'm telling a little story, or I could do it in a very structured way. Say I do it like I'm telling a little story, then we have AI tools that can say they'll take my story and turn it into a very structured report that lists all the organs one by one and what I said about each one of them. And then it makes it a little bit more systematic, a little bit more repeatable, and a little bit easier sometimes for the person who's going to be looking at the study to read. Or it can generate an impression. I can describe all the findings, and then it will generate kind of the one-liner at the bottom that's supposed to say kind of the summary of the most important findings or the take-home point for that study. Again, it's not substituting me looking at the study and recognizing what's normal and abnormal, but it's helping me generate the report, which is kind of the final product, much more easily, more seamlessly, perhaps, than it could otherwise. So yeah, so we're looking at a tool that might be doing this. And again, UCSD already uses this for work list and triage. But regardless of what AI does, I do want you all to know that there's a big workforce shortage of radiologists. We need more radiologists. As this one of these articles here says, that the state is projected to face a shortage of 17,000 to 42,000 radiologists, pathologists, and psychiatrists, according to the AAMC. So regardless of whatever you think AI might be doing, we're still going to be probably under-resourced with radiologists. But again, despite the fact that I have very long lists of work to do, I love my job. I love doing what I do. I consider myself the doctor's doctor. So kind of helping the doctors take care of the patients, diagnosing the patients, doing what I can to kind of further patient care. So, all right, that's all I kind of wanted to cover today. I'm happy to take any other questions.
If anybody doesn't have any questions now or can think or thinks of questions later, they can always put them in the exit ticket that will be posted later. And we will get back to you as soon as possible on those. Me and Dr. Santian will both answer them and send back responses if you have any questions.
All right. Well, thanks for inviting me today. If you have any questions or if you want to email me directly, I'm at csantian@ucsd.edu. Happy to answer anything there as well. But thanks for the opportunity to talk with you guys.
Would you want to put your email in the chat?
Sure.
Once you fill out the exit ticket, feel free to leave. And thank you so much for attending.
Yes, thank you everyone, and also thank you again, Dr. Santian, for guest speaking for us today. And yeah, if you guys have any questions for her or Jaden, you guys can put it in the workshop exit ticket or just in chat as well. We will stick around a few minutes after. But yes, thank you everyone for coming today.